So as I said, love and medicine are like when it is so. When we are young, we believe it is always. And as a young surgeon, I thought that my repair would be forever. Just because, well, it was justified because of my dedication, the efforts I was putting on. And with time, I just saw that this always could be questions. I've seen some patient coming back. Now, what are we talking about? This is after repair. I'm not talking about the classical myectomy that we already saw or the aortoventricular annuloplasty, because it has been told. I will take other forms. After repair, usually it's a subaortic stenosis that is not there before surgery and will be either unveiled or provoked by the surgery itself. And it's usually a problem of the septum underneath the aortic valve. We have here what we call the atrioventricular canal. We will look at that. But then we have all the forms of malaligned VSD, posterior malaligned VSD, or even the anterior malaligned VSD. And I will put a lot of stress on my talk on realignment of the septum, because I think this is something that will prevent later on subaortic stenosis. But let's have a look on the AV canals first. We know the anatomy of a normal heart with a large inlet and a large outlet, and mostly this part is free here. We have pretty much room between the septum and the mitral valve itself. In the AV canal, the inlet septum is much shorter. The VSD is on the inlet part, a very large piece here, and you can see that we have a very long and very narrow track between this part of the ventricle and the aortic valve here. Frequently, we also have accessory tissue. What should we do to avoid subaortic stenosis? First of all, I think we should operate those kids pretty much soon, at 3 months up to 6 months, because the septum is still very much elastic, and I think the free operation reduces the subsequent formation of subaortic stenosis. But it's not enough to make the repair. First, we also have to resect all the tissue in the outflow tract, because they're not producing a stenosis at its part, because everything is so enlarged. But with a patch here, we will have the problem. So those accessory tissues should be resected. I myself always cut the anterior bridging leaflet, and then I can clean out the outflow tract very nicely. We sometimes have tank tissue here. I also think that this tank tissue should be resected. Don't believe that the pressure in the left ventricle will be high enough to push it on the right side. It would fold on itself and still provoke an obstruction. So it should be resected, or at least pulled up in the right ventricle. And then we also have some muscle sometimes, which is hypertrophic here, and I think it should be also resected at the time of the AV canal correction. The way I do it is, when I have put my patch on the right side of the septum, I usually look underneath that, and if I think that it can be a little bit narrow, I do a myectomy, just the same way we do it from the aortic valve. Not before, because you need to have good tissue to anchor the patch, but after that you also can mobilize the patch and really cut this septum very precisely. So a myectomy is indicated in some cases, and I think this will reduce the incidence of subsequent stenosis. Now, the VSD, we have two kinds, posterior malalignment and anterior malalignment. We know this pathology here. It's usually associated with a problem here, underdevelopment, either coarctation or even an interruption of the aortic arch, BOT, and we frequently have bicuspid aortic valve, and it's here to a narrow LVOT. This is a typical example. You see the aorta is a bit small, the pulmonary artery is much larger. It's small because you have only 3 vessels here, which are perfused through this vessel here. And there too, it comes low, we usually can see that. Well, should we do a direct closure? We will see that later on. Just to pull up, this is the VSD from the tricuspid valve, and the aortic valve would be here, and the conal septum is here underneath the aortic valve. If you do a direct closure, you will bring up the conal septum, but it's usually very difficult to do, because those kids are operated in the first days of life. Usually the aortic annulus is only 6-7 millimeters, and I've never dared to do that. But I've done on those cases sometimes a prophylactic myectomy. Again, putting the patch here, pulling it up, and resecting some muscle here, the aortic valve would be there. And I think it's important to avoid rigid patches, because they can compress on the septum underneath the aorta. Now, anterior malalignment, and this is where I will put most of my talk, and we will see Fallot's DORV, double outlet right ventricle, up to TGH. We will start with the Fallot tetralogy. This is how we depict it, with an anterior, the conal septum here with the anterior deviation, and the other one which is here. This is how we see that. But when we operate, the key is on in a lying position, the heart is arrested, and we are in a diastolic, completely relaxed heart. And this is how it appears. The left ventricle is below, and the septum falls down, usually. And if you close that, just like that, with a rigid patch, you can get a stenosis under the aorta, which is extremely which is difficult to understand, but this is how it happens. We have said here, the conal septum here, and you see that here, we have this patch, this is a TEE, again, this is a posterior part here, and see the septum is pretty much posterior here. When we close that, this is what we usually see. This is a case after Fallot, which came back with a subaortic stenosis. And you see here is the conal septum, the septum here, the patch is there, and here a membrane is built up just because there were turbulences, and after a few years, you have a very severe and significant stenosis. This is what we call a septum en baïonnette. Now, if you realign the septum, you will have a straight way here in the left ventricle. You can see the septum has been put together with the conal septum. It does not disturb the aortic valve. It also opens up the right side here, and I do think that the aortic valve will also be better supported and probably will give less problem than in the typical Fallots. This is the way we do it. First, we are from the right atrium here. This is a tricuspid valve. I take the anterior leaflet of the tricuspid valve from annulus away because we have all the chordae. And then we can come to the VSD, which is there. And as you know, the cono-arterial VSD have two limbs. And they start here. This is the inferior limb. This is the superior limb. And we start here, a full thickness bite. Here, this is where we got the block, but not there. And we'll bring this septum on the conal septum here. That is, we straighten up the septum. You can see that here. And open up the left atrium. And for this part, we also put a patch just to replace what I would call the membranous septum to avoid some traction on the tricuspid valve or on the conducting tissue system. And this is the result at the end. Again, a very straight outflow tract. We see here the suture line and also an opening of the right side of the right ventricle. And then we had this principle that we have extended to other pathology, double outlet right ventricle, which is just a bit more than a Fallot. And we will see a case of a patch stenosis. As I said, the patch itself, if it's rigid, can cause a subaortic stenosis. And we will even go further down on a TGA and pulmonary stenosis, which is just a continuum between Fallot, DORV, and TGA. First, the DORV. We know that we no longer have a continuity between the mitral and the aortic valves. There is some tissue here which brings the aortic valve in the right ventricle. And if you just close your septum like that, you will end up with a stenosis. This is almost unavoidable. There is a technique when we can put two patches, you know, a patch vertical here and horizontal there. Usually you need an atriotomy for that and ventriculotomy for this one. And if you do that, you have good chances to have no stenosis. But still, it is a very complicated way to reach, for the left ventricle, to reach the aorta. And I must say, even in DORV, we were able to realign the septum almost in all of them and not having any stenosis. The only problem is how big is this part here? Because if it's too big, you will not be able to do that. And you have to reduce that, and we will see an example with a transposition there. But the two-patch stacking might be something that you can consider on those cases. I personally don't believe in this situation here. This is a inlet VSD, and you can see a DORV with two valves coming from the right ventricle, and the technique has been described from the inlet VSD with a big patch here, a turn there, another turn here. I just cannot believe that this will be unobstructed over many years. Second problem is how will this tricuspid valve function with so much material there, even if you reimplant something like that. And I personally, if there would be only an inlet VSD between the two ventricles, I'm not too sure that we can really do that in a biventricular repair. Well, this is my personal conviction in those cases. But otherwise, when the VSD is more or less subcommitted, usually you can connect the left ventricle to the aorta without much problem. Now, patch stenosis, this is just an example, but we see those cases much more than we believe, and they do happen. This is an example, I give you the example, it was a DTGA VSD hypoplastic of the aortic arch and coarctation. We know this pathology here. Usually we have side-by-side great arteries on that. We did an enlargement of the aortic arch, an arterial switch operation, and VSD patch closure. And the kids came a few years later with a subaortic stenosis. Just to remind you, this is what we have after an arterial switch. With the Leconte maneuver, the pulmonary artery is here over the aorta, which is very posterior and very short. And when we reoperate here, it's not so easy to cannulate, to cross-clamp. If we want to go here, we have to reopen up the pulmonary arteries. And it's not so easy operations to do. This is what we have on those cases. And you can see here's the aortic valve. Here, probably the patch here, which is there. And here's the membrane, which has built up just because of the turbulences, which were created because of this bayonet here. And this is what we see, significant gradient here. How would you go from here? We usually open up the aorta and work under the aortic valve here. But if you cut too much, you will end up with a VSD. If you only resect the membrane, it will come back, because the reason for that was this angulus here. So we went to this case from the atrium, resecting the patch, remobilize the septum, and put it here on the anterior septum. And this is the result after the surgery. And you can see here, we have an aligned septum here, and the LVOT is wide open. And I can tell you, as a surgeon, it was very I would say convenient to avoid anything on the ascending aorta. It was done from the right atrium. And if I put the color, you can see there is no turbulences anymore. And I guess, I hope, we will not have a recurrence of this problem in the future. Now we go one step further. We saw the DRVOT with some material here between the mitral and the aortic valve. The second one is the transposition of the great arteries, where the pulmonary valve is here and is stenotic. And we know that. This is the example here. Typical, the left ventricle, usually the VSD is not very large here, and we have a lot of material between the left ventricle and the aorta. Well, we all know the Rastelli operation. It was done like that. We connect the left ventricle to the aortic annulus here and put a homograph there. Just look at that. We have the pulmonary artery in an orthotopic position. That is, it comes like that and underneath the aortic arch. Now, we have seen all this article published 10 years ago from the Boston group from the drawbacks of the Rastelli operation. When we see that, I can tell you, this is not so much this curve which is disturbing, but this one. Why? Because here on the RVOT, you always can reoperate, do something, and have a good result. But when you reoperate on the LVOT, it's much more difficult, and you don't have good solutions. And that's why the Rastelli was a little bit attacked, and we looked for other solutions for that. Now, you will tell me, well, we have to need to wait 15 years, 10 years to know what the procedure is like. Not really. If you can see here, after 5 years already, you had the problem. And I think now what I would like to tell you is the Rastelli had a very bad reputation a few years ago, and I think it's unfair. It also can be a very good operation. Why was it there? Is it what we have today? First, we have to remember this series was done when we were doing a BT shunt first, a second one, and the Rastelli came off after 2 years of stenosis, and the septum was extremely fibrotic, hypertrophic, and difficult to handle. And the second thing is this is a Boston group's technique. They were putting some kind of conduit here, a Dacron tube, connecting the left ventricle to the aorta. And to me, this is no wonder that we might have a lot of problem within this tube here. Now, if we do what I call a modern Rastelli, that is early repair, usually after 3 months, even before if you need a BT shunt, when the septum is very much elastic, it's not hypertrophic. Second, you have to resect this corneal septum here to have a very straight line, not even the corneal septum. If you have some kind of valve here, it's stenotic, but the less stenotic it is, the more the problem you will have, because the aorta is far away from the mitral valve. we do a horizontal plication of all this area here, so that the pulmonary valve or annulus is plicated in this direction here, bringing the aorta towards the mitral valve to reduce the distance between the left ventricle and the aorta. This is what we have done. If I look from the side, if you do only that, and you have here something hypertrophic, you have a stenosis, even if you do that with a double patch technique. And this is why we did the Nikaïdoh. The Nikaïdoh, you take this part here, and you bring it down here, you restore the mitral aortic continuity. And in the Nikaïdoh, this is how it happens. You have no problem at all again, but you have a Leconte maneuver here. Well, there are good indications for the Nikaïdoh, but I think still there are some problems. We are transferring a valve. Sometimes it doesn't work as it should afterwards, and still the coronary arteries are reimplanted. And when we look at the coronary arteries after an arterial switch, they never develop exactly as normal ones. And I think also the denervation, like Felix was mentioning this morning, plays a role in the development of the coronary bed. So it's a good technique, but I think if you can still do a Rastelli, you should stick to the Rastelli, because it leaves everything in nature as it was. And what we modified in the Rastelli, we removed that, we made the plication anterior-posterior here. We do that much sooner, so the septum is still elastic and you can bring it. And this is the way we do it most of the time, and usually you have no problem here because you have squeezed everything there. Now, what we have also done, a little bit like for the Nikaïdoh, instead of cutting lateral to have the pulmonary artery lateral to the aorta, we also cut transverse here, leaving a little bit of tissue there so that we could restore a communication, connection between the septum and here the anterior wall. And we were able to do that on a few cases. But in these cases, we had, you know, the homograft or the contegra really above the aorta, and I don't like this. And I went back to the technique when the contegra was a little bit lateral. And I must say we had also very good results for that. So this is an example here. You can see here we've taken a lot away from the coronal septum. We reduced the length. The pulmonary annulus has been squeezed between the aorta here and the pulmonary valves there. So this distance has been reduced a lot. And here we have the direct connection of the septum to this coronal septum here, or to the, it was the free wall of the right ventricle there. And there is no stenosis at all on this case. Still a little bit of bayonet effect, but I don't think that it should make any problem with the future. This is another view of this case. So in conclusion, I think the reduction of subsequent LVOT are really dependent on the clearance of the LVOT. We should reject anything that can disturb the flow of blood here. In my opinion, the alignment of the septum can play a very good role, a very important role, and also the choice of patch material. And just to come back on that, always, I'm not too sure, but if you do things right, I think, at least for a long time. Thank you.